Good afternoon. I believe we're all afternoon now, so I will commence with the talk here. And so I've got a nice collection of 3 people in the live audience, and then it looks like a few more up there in Queensland. And I do appreciate your willingness to come and listen to me today. So I'll be talking about health behavior change, as Anthony mentioned there. And what I'd really like to leave you with by the end, so I'll say it now, but I'm hoping that you will be convinced of this by the end, is that we really need to be thinking about human behavior and being able to understand why it is that people are doing what they're doing and how we could predictably change that or look at changing that for the benefit of public health, for the benefit of the person's health. And that's going to be crucially important if we really want to look at population health and changing from how we are now to a healthier population. So human behavior is going to be really important. And of course, the overall way to say that would be if we want to be well, we need to be well behaved. And that just means having our behavior consistent with the outcomes that we're hoping to see within the population. Now, we do have a lot of challenges standing in the way of that happening. So right now, we've got an aging population within Australia and much of the Western world. So we're getting a lot more people in the 65 plus and also the 75 plus, 85 plus, 100 plus populations. We've got more proportionally than we have before, and we certainly have more in absolute numbers than we've had in previous generations. We also have a very unwell population in that if you look right across the age spectrum, you see some problems going on with chronic diseases, with obesity, overweight, and the metabolic consequences of obesity. And we see rising rates of diabetes, particularly within the adult and older adult populations. Well, we know that lifestyle, or a collection of behaviors that we could call lifestyle, really has a big impact on health. And we could call it determinant of health. So we can look at things such as diet and physical activity, alcohol, tobacco, sleep, and even sexual behavior, and know that that has a big impact on the kinds of outcomes that we're seeing within the population. I'm going to talk just a little bit about implementation science, but the question and the challenge is, given the wide body of literature that's out there, thousands of studies being archived every month within Medline or PubMed, and if you look on Google Scholar, you see no shortage of a flow of research out there. And we do have some evidence around what has been shown to work, but we have a lot of difficulty implementing that within healthcare, implementing it within public health and community settings. And so the question is, how do we better deliver on what works? Okay, I'm hearing some feedback there, so let's mute the microphones, please. Behavioral health, and here I am trying to change people's behavior, unfortunately. Behavioral health, if we look at substance abuse and mental illness, these are huge issues, certainly within the American context, and my understanding is also in the Australian context. And I won't talk much about those, but we could think about how the issues I'm raising today really apply to those as well. And then health disparities, when we look at, you could say the indigenous population versus the rest of the population, or people of low means, low socioeconomic status, or racial and ethnic groups, we can often see that they have a different level of health burden than the rest of the population. And it behooves us all to reduce those disparities within the population. Then another large challenge is, how do we get away from working only at one level, or working at, especially at the individual level, with people or with interpersonal levels at the lower end of the socio-ecological model? And how do we take what we know around behavior change and apply it to structural interventions by changing policies or changing the systems and the environments in which people live, learn, work, and play? So some big challenges there, as you can see. And of course, I won't have the answers to all of those, but we can just put it in the context of what we're talking about. And here we're looking at the deaths in the world. So a few years ago in 2016, if we looked at the people right around the world who died that year, we can assign one main cause of death to that, and here's how it stacks up, with certainly a large majority of those dying of cardiovascular diseases and cancers, respiratory diseases, and diabetes. And then you start to think about, what is it that you see on the nightly news, or what is it that people are Googling when they're looking for issues around mortality? And you'll see right there at the bottom, issues such as fire and conflict, like wars or terrorism and natural disasters. These are what really captures, these are the issues that capture people's attention. But you can see that even if we add up all of those numbers, they don't add up to as much as drowning deaths. And what's really killing people in much greater numbers are these fairly mundane chronic diseases at the top. And so we've got a disconnect in how we're thinking about these diseases and how we're treating them with attention, certainly within the media, but also, again, Googling these issues, people tend to look for things that are out of the ordinary instead of what's ordinary. So the World Health Organization looks at issues of chronic diseases and mortality around them, and we see our top 4 there from the previous slide: cardiovascular diseases and cancers, diabetes, and chronic respiratory diseases are some serious outcomes that we would really want to be driving down within the population. And we know a lot about risk factors, and we could say the flip side of that, the protective factors around those diseases if we want to protect people from having them or look at why they're getting them. We can look at these intermediate risk factors. Certainly clinical values that we study would be blood sugar, blood pressure, lipids, the overweight or obesity status, and then abnormal lung function. But we know that upstream of that comes these other drivers, and we can look at in the red box there some common behavioral risk factors of tobacco use, unhealthy diet, physical inactivity, alcohol use as major behavioral determinants of those downstream consequences. And then we could add to that things such as air pollution, which I could argue that there is some behavioral component to that, especially when we look at open air cooking and secondhand smoking issues around air pollution. But then we also have these non-modifiable determinants, or mostly non-modifiable, in that we could look at age. We can maybe change some of the consequences of age with some of the emerging technology. We might be able to do some gene editing and some of those things, but traditionally we think of them as less modifiable factors. And then those things, we don't want to point the finger of blame too much at the individual making the choice, as we would say, to smoke or not smoke, or to be inactive or not, because there are a lot of determinants that are sitting upstream of that individual, with what's going on in the economy, what's going on in politics, and what would be going on just in terms of changes that are downstream of technological consequences or the way that things are being done within society. Here are some data from Australia, and so this is AIHW data from just recent data looking at deaths, again, mortality right across the life cycle. And so the behavioral scientist would be looking on this list to see, is there anything on there that's really killing a lot of people, and is there anything that we can do about that to prevent it? And you could look at an issue such as SIDS, or sudden infant death syndrome, and think about what are the risk factors for sudden infant death syndrome. And you probably know some. If we take a baby and put it to sleep, we've learned that we should put it on the back, right? So that would be a risk factor that was identified in Australia. Actually, to reduce sudden infant death syndrome, we want to put the baby to sleep on the back and be careful about how soft the mattress is and the bedding around the infant, and even smoking. Those are some controllable behavioral risk factors that if we want fewer infants dying of SIDS, then we can change those behaviors to reduce that. And same with drowning. So I would argue probably that, at least in theory, 100% of drownings that are occurring are preventable through behavioral change in some way. Again, in theory, in a perfect world, we could prevent pretty much all of those drownings. And then we look right across the life cycle and we see motor accidents. I was walking yesterday along a very busy street and looking, as I often do, what people are doing when they're driving. And I was really pleased that I could not find a single person out of about 50 cars that I watched go by fiddling with their smartphone. Whereas in my college town, a lot of the students are driving around with the phone in one hand and their other hand on the steering wheel. And so then I watched the news last night and they were talking about $1,000 fines for people who are doing that. I thought, well, that's a way to change behavior apparently, or maybe it's a cultural issue that's changing behavior, and this is just a reinforcer of that. So that's a big issue, that we have people dying, motor vehicle accidents and such. And then as we look later in life, we can talk about these non-communicable diseases, these chronic diseases such as heart disease, lung cancer, coronary heart disease, that are really taking a big toll on the population. And so again, from the behavioral perspective, what can we do to drive those numbers down? And I made this joke the other day that when we're looking at mortality and trying to reduce that, we really want very few here on the left side. We want them to be much later in life. And so what do we say to the God of death? According to Arya Stark, we'd say, not today. We want to put that off quite a bit later in life. And then we look at how do we get there. So we can look at these risk factors again, such as the environmental risk factors of air pollution. We could probably add water pollution. In America, we have a problem right now with lead in the water supply in Michigan and elsewhere. And so we need to reduce those environmental risk factors for negative health outcomes. And we can look at these metabolic risk factors that would be probably midstream consequences of what's going on prior to disease and death. And we have ideas about what's related to them and what's causing them. But then upstream of that, we can think about, here's what's putting people at risk, is some of these behavioral risk factors. And these are the big four, with diet, tobacco, physical activity, and then substance use, alcohol and drugs included there. And we could estimate, again, if we have to be a little bit reductionist and think about what is the one thing that's driving this, we could look at diet contributing about this much from cardiovascular disease in the light blue, and so on. But that's just an idea. We don't know how certain those are. And of course, diet and physical activity, these behaviors tend to cluster. So it's pretty difficult to separate them, really. Okay, so if I switch gears for just a little bit and talk about some more aspirational health outcomes, we often think about death and disease as things we want to avoid, but what do we really want out of life? And most of us would probably want to have excellent health and excellent quality of life if we were asked, if we had to choose. And so a few years ago, some colleagues and I looked at some data from the 45 and up cohort, which would be people in New South Wales who are aged 45, all the way up to 106 was the oldest person in that cohort. And we were interested in behavioral risk factors or protective factors, however you want to look at it, related to excellent health. So again, that aspirational health outcome of something that people would want to get instead of not wanting to get. So what is the likelihood of having excellent health and quality of life? We modeled that according to both physical activity and sitting time. And so we've got on the x-axis here, sitting time. On the z-axis, I guess we'd call it the physical activity category. And so what you can see there is that as we get more physically active across sitting categories, we have higher likelihood of reporting excellent health. And that's adjusting for the usual confounding or nuisance variables of age and household income, education, smoking, marital status, weight status, where the person lives in terms of rurality or remoteness, functional limitation, and chronic disease. So even controlling or holding all of that constant, we see that greater levels of physical activity are related to higher likelihood of excellent health. And as we look across sitting, less sitting, more likely to be reporting excellent health there. So we see a combination or an interaction between those two, sitting and physical activity. So a different data set, this is people who signed up for the 10,000steps.org.au website. So they're tracking, and they've been tracking, I don't know, Cornel's going to present on this on Friday in a different setting here. People who've been tracking their steps on a website, and there's something like, I don't know, 1 million or a very high number of people who've done this across the years. And so we looked at some of the data from this, 6,000 people several years ago. And again, looking at their likelihood of reporting excellent well-being. So just a slightly different outcome there, but how likely is it that they're reporting excellent well-being? And we looked at several lifestyle behaviors, smoking, diet, physical activity, sitting time, and we've added sleep now to the equation. And what we're seeing here is that comparing lower risk to higher risk, people who are in the lower risk categories are more likely to report excellent well-being, and that was true for most of these, but then when we adjusted and used these different models, it dropped out for, interestingly, smoking and alcohol. And I think that's a healthy cohort effect, where we had people who were just a little bit out of the ordinary from the full population. But as we look at these, we start to compare to those who are reporting the fewest lifestyle behaviors. As we add one, then we see increased likelihood of well-being. So it's just a cross-sectional data set, it's just associations, but it looks like the more of these that you sit in the lower risk category, the more likely you are to have excellent well-being. And personally, that's what I want, is to feel good. Now, feeling good does not necessarily drive policy, and it doesn't pay the bills oftentimes. So we're often driven by avoiding death or avoiding mortality and morbidity issues. And when we look at something as simple, a behavior as simple as properly washing one's hands, we know that that can have life or death consequences. And just in the European context, we see about 14 deaths per day associated with water, sanitation, and hygiene. And that's not in the developing world, that's in the European region. And then we look in hospitals and the hospital-acquired infections. You know, when people go to the hospital, they don't go there to get an infection, they go there to feel better. But unfortunately, they're oftentimes in an immunity-compromised situation. And so if there are bacteria or viruses around, they're more susceptible to getting those. And we see that hand washing can reduce from 1 to 8 infections to 1 in 20. So make it a lot more rare, and that's what we'd like. We'd like people to be washing their hands, and of course when the physician or nurse or person comes into the room, we'd like them to be touching us with clean hands and not touching us or touching things around that we could be infected by. But there's a lot of barriers associated with that, and it's a question that often you would scratch your head and think, why are these people not just complying with the most basic thing? We don't want to get people sick, so we need to have clean hands. Well, they studied nurses, and this was in an intensive care unit, nurses, actually directly observing them, so it wasn't like a secret camera. They actually knew they were being watched and studied. And the researchers found that carrying something was a barrier, putting on personal protective equipment, pushing or pulling workstations, and using a mobile device. Those were barriers. And then they saw some high performers and what was likely to drive good hand washing were some of these issues around basically internalizing those standards, not doing it for external reasons. They'd been exposed previously, they didn't want to make that mistake again. Pregnancy incentives, so these were more the external incentives there. But then we looked in a different context here in a pediatric unit and studying mistakes that were made in hand washing. Again, this would seem to be a pretty simple behavior, that we want to protect people from getting bacteria and viruses. How do we do that? Well, washing hands is a big part of that. But you see people make a lot of mistakes and they take shortcuts with this. And so not washing the digit between the digits, or the fingertips, or the finger articulations, or the thumbs, or the wrists, back of the hand. So there's a lot to it, and personally I know I'm not very good about this, but luckily it's not usually life or death consequences in my job. It's more of probably infecting myself. We also could look at medication non-adherence. We could put together a set of behaviors that are people more likely or less likely to comply with doctor's orders, or are they doing what they're supposed to do in terms of taking the pills or using the biomedical device or some kind of a medication issue. And if we modeled that in the United States, basically about every 8 years, we'd reach 1 million deaths from medication non-adherence. And I was listening to a podcast actually earlier today from Freakonomics, and these guys are economists. You listen to those guys or read the book Freakonomics, and they were talking about exercise and the 0-minute workout. So the ideal, if you've heard this episode, it just came out a few days ago. The idea is a 0-minute workout, that people will not do physical activity, so we should put it in a pill form and try to replicate the same benefits metabolically and physiologically that we could get there. And I would contend, even if you did that, there's going to be a substantial part of the population that will not remember to take the pill, or they will have some side effect or something that stands in the way of their fully complying with that. And so it really still will come back to behavior. Of course, as a physical activity, I'm biased toward physical activity. I think there are a lot of benefits that we'll never be able to get into a pill. I even sometimes find money when I'm out running, but usually it's more just seeing something beautiful or having some nice interaction with other people that probably not going to get in a pill. So other issues that we could frame as behavioral issues and behavior change issues would be something more severe in a hospital or surgical area where we're looking at mistakes that are made that have potentially life or death consequences. In this case, we've modeled medical error as the third biggest killer in the United States after heart disease and cancer. So quite a few numbers there. And we could look at up here on the upper right, we've got an X-ray where they've left a surgical instrument behind after they closed up the patient. You know, serious errors like that, that's going to cause a lot of problems for the person. And then issues where we've accidentally amputated the wrong appendage. Those are pretty serious medical errors, and of course we don't want those to happen. And we could think about that as people doing things that are right or not right, and could we somehow change those behaviors or change that environment so that it prevents or reduces those kind of medical errors? That's the dream. So how do we get there with that? Well, there's certainly a lot to it, but the area of implementation science is emerging as a pathway to improve evidence-based healthcare, evidence-based medicine, public health as well. And so implementation science is studying methods to take evidence-based practices and interventions and policies and put them into routine healthcare and public health settings. And when we do that, we see better population health. So it's really looking at, in the real world, how do we take evidence-based programs and make them work? And can we bridge the divide between research and practice? So we've got this problem where something around 14% of the research evidence takes about 17 years actually to show up in practice. So we've got this, you know, those are numbers that could and probably have changed, but a very small percentage of breakthroughs in science actually make it into practice, and it takes a long time for that to happen. And we need to speed that up and make it better. And if we do that, we can reduce costs, we can improve health outcomes, and decrease those health disparities. And just a couple quick examples of this would be looking at using checklists, and certainly that would be a tool, and any tool can be used and misused. And so it's not necessarily that the tool is the answer. And by extension, then when we look at information technology tools, we could see the same thing. They're probably not going to solve the problem by themselves until the robots take over completely. Maybe they will. But we could take a tool like a checklist and realize that aviation has become incredibly safe. And so when I get on Qantas Airlines to come to visit Australia, I know that it's the #1 rated safety airline in the world, and they're probably using a lot of checklists in terms of understanding whether the plane is suitable for use by passengers. And you can think about what's at stake there. What's at stake is not only the lives of a lot of passengers and the careers of the people who are doing that, but there's a lot of economy related to being able to fly safely around the world. The economy is hugely based on that. So there's pretty good incentive to be by the book. And I know Anthony does a little bit of flying, and so he knows the power of the checklist with aviation. Can we take that from aviation and use it in health? Well, yes, we can, and it's being used, and you see a couple of examples here of this pre-operation checklist, and this is a plastic slider board, so it's pretty low tech. It's just plastic vinyl, and these little things are raised on the surface, this black thing, and you can slide it to the green or to the red. But you're kind of going through and making sure that it's all green before you go and do the surgery. And then you can see this in situ here in the real world surgical safety checklist, and you can see a number of these different things around sign in, time out, and sign out. And so it's being used. Again, the tool is only going to be as good as the surrounding context and how it's being used. So there's still a lot of aspects beyond just the use of the tool there. Beyond checklists, we could look at quality improvement more generally, and we think about issues of over time, looking at what's going on, making little changes within the system, and it usually is a system, making changes, studying the impact of those changes, and then continuing the process on forward. And so we look at something like the evidence-based interventions that are out there, Well, we need to take those and also consider the stakeholders and what do the people want and need, and does that evidence really fit with the context, local context? Because if it doesn't, we're going to have a lot of problems. We might need to adapt it, especially the less fit there is between what's been shown to work and what's likely to work in this context. We might have to adapt it. And we certainly need to think about fidelity. We need to be preparing for them to be able to deliver the intervention with fidelity, or else the evidence is really not going to be applicable if they're not following the protocol. When we do implement, we can use a number of theories and models and frameworks, basically a lot of science around what works and theories related to that to help us to succeed. But then we still have to evaluate it and think about, did it work? Did it not work? Why not? And then we go on and continue the cycle. And then this is just a basic formula for success within that. And we can think about each of these blue blocks as a number between 0 and 100%. And if we've got a very effective innovation, but we put it in poor implementation or not an enabling context, it's going to lose a lot of power. And so we really need to be maximizing the power, or the percentage of innovation, the percentage of implementation, and how enabling those contexts are if we really want to get the most out of this. When we do that and think about that context, of the enabling context, we have to realize that we're often working at one of these levels. It could be the individual level, it could be the interpersonal level, but that context is going to continue on well across here. And in the American healthcare system, we have policies and laws and even cultures that can interfere with our best efforts to improve health, especially when money might be driving the equation, or something around the way that medical students have been trained is going to be impacting our likelihood of that. And so it's just a bit of a heads up here on the social ecological model that we have influences on health and influences even on healthcare and public health that cross these boundaries of levels that we need to be aware of and think about. Are we dealing with all of those effectively? Are we maximizing our ability to make progress across those levels? So I'm going to tell you a little bit about a few of my successes and failures at Kansas State University. And you see the picture there of Anthony visiting us a few years ago at Kansas State, where we've got the Physical Activity and Nutrition Clinical Research Consortium. We've got a few of my former students. I think all of these guys have moved on, gotten careers started in the field. And so with me, I often describe my work around the behavioral epidemiological framework, and this is a systematic sequence of studies that lead to evidence-based interventions for populations. So this is really what we've been talking about already. And I just like to think about, where does my work fit in to the bigger picture? Sometimes it's these links between behavior and health, and you saw that example earlier around excellent health or excellent well-being. Oftentimes we need to develop better measures of the behavior. That can be very tedious work, but I know a lot of you are probably working on areas around how do we capture this phenomenon that we're interested in. And it might be some kind of a digital phenomenon, or is a person engaging with the intervention, and what are the metrics that we use to establish that? The influences on the behavior, so thinking about those drivers, what is it that's making a person more or less likely to engage with the behavior? And then looking at evaluating the interventions to change the behavior, and eventually translating the research to practice. So the yellow and orange there is where most of my work falls in the 3 and 4 levels. I've dabbled in all of them, but most of my work is in 3 and 4. So I focus on modifiable influences of health behaviors, and that's mostly the healthful eating and physical activity. I'm really interested in the person-environment interactions within behavioral settings, and why is it that the person is doing or not doing what the guidelines say, and why is it that they're doing it in this setting but not in that setting, those kind of issues. So here's a big picture research question that really frames a lot of the work that I do. What are the effective methods for developing and implementing, evaluating, and disseminating those evidence-based interventions, and particularly those that build the capacity of people who work with youth? So when you're a leader, like a teacher or a coach or a caregiver in a youth population, what is it that's driving those decisions that are made around offering healthful eating opportunities such as fruit and vegetable snacks, or sitting and playing computer games, for instance? And one of the models that's been put forward that summarizes a lot of the theoretical literature around behavior change, trying to simplify it, is the COMB model from Susan McKee, I guess is her pronunciation. And we look at these three components of capability. Does the person or do the people within that population have the capability to do the behavior that we're asking them to do? And do they have capability to do the behaviors that are leading to poor health as well? Do they have the opportunity? And that could be both physical and social opportunity. And then motivation. And so each of those three is pretty important. We're looking at predicting and explaining, but also changing behavior. That if one of those is missing or severely lacking within our constellation of factors that are related to behavior, we're probably not going to see much in the way of the behavior that we're interested in. This is just a bit more of that same COMB model, but it's making the point that each of these CO and M have subdivisions where we can look at physical and psychological capability, reflective and automatic motivation, and the social opportunity, but also the physical opportunity. And the motivation aspect that a lot of us think about, we think that oftentimes for people that they're just lacking motivation, but that actually has to be stronger towards the target behavior than it is to the competing behavior. And so if we think about something like eating a ultra processed food versus eating our fresh fruits and vegetables, well, it's pretty easy to look at why people might be more motivated for this one than they are for that one. So what are the drivers of capability, opportunity, and motivation, those COM factors related to physical activity and healthful eating, and how can interventions most effectively modify those drivers? I've talked a little bit about setting, and Barker was a theorist around why is it that people do things in one setting that they don't do in other settings? And if we're interested in this behavior that's related to health, where do people do that? Why did they do it there and not here, for instance? So there's a whole lot of research related to that. He described it as an eco-behavioral science, that it really, he minimized the influence of the individual's characteristics and really maximized the thinking about the environmental circumstances. And the examples I was thinking of today was our big four issues of smoking and alcohol. If you grow up in Indonesia, for instance, it really doesn't matter too much what your individual characteristics are, because you have a pretty low likelihood in population numbers of using or abusing smoking and alcohol within that setting, right? If you grow up in Australia, on the other hand, you have a really high likelihood of driving in a car and getting around from place to place in a car, and that's going to replace a big part of physical activity. Again, there are exceptions to that, but if we look at the general numbers in the population, that environmental context is really driving, so to speak, what's happening there. So to use that information, we want to create healthy settings, and we want to be thinking about ways to implement practices, programs, and policies that promote health. And to do that, we need to think about the individual's connection within the group, or how the group is connected socially. We also need to think about whether people actually have autonomy. Do they have an ability to make choices within that, or do they have a sense of autonomy? Do they have the skills? This, again, you can already make the connections here to the COM model. And then healthy norms are going to be that social component, that if everyone, in the nurse's case, if everyone is really diligent about washing their hands all the time, or cleaning their hands before engaging in a risky operation or something, then it's going to help that person operating within a set of healthy norms. And we also use the quality improvement process here as part of this. Getting low on time here, so I might rush through a little bit of this, but we're thinking about, for me and my work, children in particular. And if we want them to eat fruits and vegetables or whole grains, or if we want them to be physically active, we have to think about where is it that they're spending their time, and what opportunities do they have within each of those settings. And here's a project that started about 4 years ago called SWITCH, and this is the School Wellness Integration Targeting Child Health. And we were looking at helping children to change what they do, view, and chew, and that would be physical activity, screen time, and sedentary behavior, and then also diet related to that. And we targeted 3 settings where children spend time. One would be the classroom, and thinking about, can we get them not just sitting all the time, but also to engage in some brain breaks or some chances for physical activity within that. Can we also equip them with some of the capability and motivation within the classroom to do some of these behaviors at home? Physical education would be the same way. Are we making effective use of the time that they have in PE? And are we encouraging them and motivating them to adopt that lifestyle outside of PE? And then the same with the lunchroom. We can look at changes within the lunchroom that will help them to make more of the healthy choices and fewer of the less healthy choices. And then can we get that to transfer to the home environment as well? So we used online training and support for the switch teams, but most of the actual business was done within the schools. So we provided training to the staff, both in person and online, and we used some motivational interviewing techniques to help them to come up with their own ways of addressing these issues within their own settings. This is a really busy logic model, but at the end of it, you see we're trying to reduce the risk of obesity, and we're doing that through the usual suspects of physical activity, sedentary time, fruit and vegetable or dietary quality. And we can look at primarily the school, and the school environment was where we had most of our impact and most of our attention was focused on that. And we also used child self-monitoring that happened a lot of times within the school environment. And each of these had some level of information technology aspect to it. So we were trying to reach the parents through social media, internet, and email. We provided a community of practice support for people out there in the schools. So each of them in geographically isolated areas had access to a community of practice support network. And then the children were self-monitoring. I'll show you a screenshot of that. Their do, view, and chew behaviors. So this is kind of what that looked like, where they were going in, typically within the classrooms. The teacher would take them as a class to the library or to the computer lab, and they would be able to monitor their do, view, and chew, to set goals, to get feedback on how they were doing in relation to themselves and also to their class. And so they did this multiple times per week. This is a bit more of the structure around the training and implementation, and I apologize, there's a lot of complexity of this project. It's got, I don't know, eight or so investigators and a whole bunch of students involved as well. But the idea around that implementation aspect and the implementation science is that we realized at the end of this, we're going to be gone and the grant money is going to be gone. And so we wanted to set it up in such a way that there's a self-sustaining infrastructure. And we used existing groups within Iowa to help basically train them up and build their capacity to handle this after we were gone and after the money was gone. And you can think about it as another example of Plan, Do, Study, Act, or the quality improvement process. And yes, there's information technology aspects built into this as well. Okay, so just really briefly, a couple of other areas that might be interesting. Worked a lot with Girl Scouts, which is a girls-only youth development program. And we were looking at basically their environmental access and the opportunities they have when they come together as Girl Scouts. Do they have opportunities for more health promoting or less health promoting behaviors? And this is actually representing something of a failure here, in that we were really trying to create such a good online intervention that it would be just as good as the in-person. And we were not able to do that. And a couple of the big barriers that we found were just access and sophistication with the Girl Scout leaders. Once they hit any kind of roadblock in the system, it was over. That they, you know, even if it were a password issue, they just dropped out and didn't engage any further. And so we learned a lot about facilitating that and making it so much easier than we ever thought we had to in terms of getting them to engage. And we've moved to a little bit different model where we're providing video-based wellness training with Girl Scouts. And we've seen within this project, we saw improvements in their confidence to deliver meetings that had healthy behavior opportunities. And with this, we looked at a number of behavior change techniques to build into the fabric of this. So we had a real logic for what the videos would contain. And then we started out very quick and easy with just a smartphone video that was personalized. And now as we've gone to scale, we've employed more professional video production that, again, is based on behavior change techniques. This is another example from the state of Nebraska where we were trying to build in some time segments of physical activity. So you can think about that as having an opportunity. So we wanted to build the capability of leaders to put in an opportunity for children to be physically active, and then also improve the quality of those physical activity episodes so that they're not just sitting around during that time. And you'll see a lot of the same factors we've talked about already. We've got this quality improvement process that we're engaging in across a couple of different years. And then we've got these settings, these multiple settings within the community. And we're trying to, again, cross boundaries of that social ecological model to address the community as well as organizations, families, and individuals within that. I'm not going to show you the video, but we've developed a really even better video now that's aimed at persuading leaders to adopt the training. Basically, we're trying to sell them on a free training that then we will keep encouraging them and building their capability to offer these opportunities and motivate them. We're also working on, this is just a draft form, so I'm encouraging them to make it a little bit more fun and colorful and engaging, but this is around that idea of building in an opportunity within the day that we're going to ask you to think about it, what it is that you intend to have happen in your after school time or even during your school time, and what supplies you need and that kind of thing. But here's the big checklist that we really want to have happen here. So we want kids to have fun, have that sense of autonomy, build their skills, have the social connections, and of course physical activity along with that. And if we can get more leaders to do this, we're going to have great success, I think. Okay, just a couple of minutes and I'll be done, but just a couple more things to think about that I'm even encouraging myself to keep thinking about because we haven't cracked this code yet. And that a lot of our work previously in public health and healthcare has been focused on system 2 thinking, which is slower, it's more deliberate, it's more logical, it's rational. But a lot of times during the day, and a lot of people don't think that way, and we think more about we think more automatically. And in times of crisis, we're really driven by visceral reactions up here in a hot state, where it's just go with the flow, kind of boring. It's just more automatic, and we're driven by what we've always done. And we need to be thinking about ways to impact behavior in both of those settings. Nudge is an idea that we've seen really increase in popularity in the last 10 years. And we know that behaviors tend to be automatic, or they tend to be defined by just what other people are doing and our own cognitive biases. And so we can employ nudges, which are any aspect of the choice architecture, which is how choices are framed, whether you have the chicken or the fish, or did you even know that there was a vegetarian option? No, we never told you that. So those kind of issues, if we can alter nudges, then we can probably change behaviors in small ways that might add up over time. And nudges are not mandates, so it's not like the $1,000 fine for using your phone. It's more like putting fruit at eye level, that counts as a nudge. Banning junk food doesn't. Here's a couple of really nice examples of that men are much better aims in the urinal when there's something to aim, something that you think might be fun to hit. And that's a fly. That's basically a sticker within the toilet. And then, of course, yes, most people will use the lifts, but what if we made it a lot more fun to use the stairs? And that's what they've done here. One of the greatest successes in this area has been maybe what you'd call superannuation, where if we make it a default, when you get a job, you automatically start saving for retirement, then people often do not change the default to take more money out now. And so that's been a major win for the nudge. A couple examples of this. This is just around the food context, but making it convenient, attractive, and normal, that's the idea. If we want people to do something that's positive for them, we have to make it more convenient, we have to make it more attractive and more normal. And then the flip of that is, if we want them to smoke less, then we've got to reduce the convenience, reduce how attractive it is, and reduce how normal it is. And I think Australia has done that pretty darn well, in my opinion. Habits are pretty important. I'm not going to get into this too much, but we see the same things of the reminder, routine, and reward. And we can think about a checklist as serving some of these functions, where it serves as the reminder, we do what we're supposed to, and we get the reward of that satisfying check the box, right? I'm driven by those. Habit is another big factor that we have to think about within this. And if we want to change habits, we have to hide the cue for bad things or increase the cue for good things. We can also substitute with the same cue. What if we change what we do during that? Same with this. Maybe we could hide how often we get these push notifications, or if it's something positive, like get up and move, then we want to have more of those. Okay, so back to the key point in wrapping up and closing here. We should align population, organizational, and individual behavior with the health and well-being outcomes that we desire. And again, looking at that setting or looking at the environmental determinants of behavior, we really need to make sure that we're aligning all of that. And if we want to be well, then we need to be well behaved. So I thank especially Anthony for getting me here with Flinders' help. Thank the funders of the work there, and then thank you at University of Queensland for having me today. That's my contact information, and I appreciate your time today.